Good evening to everybody. My name is Antonio Cittadini from Naples, Italy, and I'm particularly glad to moderate this webinar with Professor Larina, since it is the first initiative of the new board working group on heart failure of the European Federation of Internal Medicine. And the topic that we have chosen, the challenge of congestion heart failure, was chosen following a poll that we did internally of our working group, and we know that it is a very timely and relevant topic in internal medicine in general, in cardiology, since we know that 83% of the patients with acute heart failure do have clinical signs and symptoms of congestion, and the treatment of residual congestion is one of the greatest unmet needs of treatment of congestion. The management itself of patients with heart failure, the treatment of congestion does not really follow guidelines, but more expert opinions. And so it's very important to discuss this very relevant topic. So it is my pleasure also to introduce my co-moderator, Professor Larina, which will say something about how the webinar is organized. Thank you to everybody.
Dear colleagues, let me greet you and introduce myself. I'm Vera Larina, full professor of internal medicine and head of Department of Outpatient Medicine, Institute of General Medicine of Pirogov Russian National Research Medical University from Moscow. It's great to see you and hear you. Thank you very much. And the main topic of today's webinar is congestion in heart failure. Clearly, congestion assessment, monitoring, and treatment represent a real challenge in daily clinical practice, and a key pathophysiological phenomenon largely responsible for the clinical manifestation and morbidity and mortality associated with heart failure. I'm glad to present our first speaker, Professor Jesús Casado, and before the first presentation, dear colleagues, we kindly ask you to write your questions in the conference chat. Thank you.
Thank you very much for the introduction. Good afternoon to everybody. And of course, in the next minutes, we are going to talk about how to evaluate congestion in acute heart failure. Let me share with you the presentation. So perhaps the first thing to talk about is, why do we have to talk about congestion in acute heart failure? As you can see, the graphic from the left represents the natural evolution of every patient with heart failure. As time passes by, patients eventually are admitted in hospital because of acute heart failure, and congestion is a problem solving more difficult to resolve as the number of hospitalization increases. And as you can see in the graphic from the right, in the context of hospitalization, no matters the department, congestion is the prevalent phenotype of heart failure patients, represented with the green and the orange colors. But how can we evaluate congestion? Traditionally, we use clinical evaluation, but as you can see in the table from the left, each of the signs that we can observe has a low sensitivity and specificity even for the diagnosis of heart failure, not just acute heart failure. And same happened with the chest X-ray. So indeed, almost 20%, as you can see, of patients with heart failure have a negative X-ray for heart failure. So in an attempt to optimize the diagnosis of heart failure, and most of all of congestion in the settings of acute heart failure, some clinical congestion scores have been developed, as you can see in the graphic, but usually only combine clinical parameters. And the truth is that none of them has been really validated for acute heart failure. The respective role of these congestion scores in routine clinical practice still remains to be determined. However, perhaps the Everest score is the most evidence-based in acute heart failure, and it appears to be the best candidate for routine use. In this context, the European Society of Cardiology recommends a multi-parametric approach to evaluate congestion. As we can see in the graphic, we have to combine clinical parameters of congestion, but also technical evaluations using biomarkers as NT-proBNP and imaging techniques as chest X-ray and also ultrasound as vena cava imaging and lung ultrasound. However, since the publication of this recommendation, other parameters can be added to this graphic, most of all CA125 as a biomarker and renal Doppler ultrasound. So what the procedure to evaluate congestion in acute heart failure should be? Well, when we assume that a patient can have acute heart failure, we have to evaluate clinical signs and symptoms, use biomarkers and point-of-care ultrasound all together. And with this information, we could not only improve the diagnosis of heart failure, but also it will allow us, we will be able to phenotype the kind of congestion, because not all congestion is the same. Today we know that there is a tissue congestion, which is different from intravascular congestion, and there is also most patients have a mixed phenotype. In the graphic, we can observe the different patterns of these two types of congestion, tissue versus intravascular congestion. Clinical signs are different, as you can see in each phenotype, and complementary tools have more or less utility depending on the phenotype. We are not plenty of time, so we are going to focus just in a few of these techniques. Clinical signs, NT-proBNP or chest X-ray are widely used and they are well known. So we are going to focus on the most novel biomarkers such as CA125 and ultrasound. Both of these, CA125 and ultrasound, I know that are techniques very used, but I think that they are not used enough and their use must be encouraged. We are going to start talking about CA125. This biomarker has a few advantages. First, is cheap and widely available. And second, it allows us to phenotype the kind of congestion of the patients, as we talked previously. Higher levels are related to interstitial edema and not with intravascular congestion. Finally, it has also been related to prognosis in heart failure patients. In this sub-analysis of the large Biostat cardio heart failure study, where 11 European countries participated, the CA125 was evaluated in clinical and prognosis settings. As we can see in the graphic from the right, levels of CA125 was closely related with a congestion score. And this congestion score was conformed with 3 signs and symptoms: orthopnea, jugular venous distension, and peripheral edema. Higher score had higher CA125 levels. And the green graphic represents the relation with the CA125. As the level increased, the risk of mortality and hospitalization for acute heart failure was higher. But we can also use CA125 to guide therapy in acute heart failure. This is a study with patients admitted for acute heart failure and also with renal dysfunction. 160 patients were recruited and were assigned to 2 arms. In the first one, when the diuretic therapy was guided for the CA125 levels, and in the second one, the follow-up was conventional. In the guide group, if the patients had CA125 lower than 35 units per milliliter, the diuretic dose was reduced, and if their levels were higher, was increased. And as we can see in the graphic, the group in the CA125 guide therapy had a better prognosis in terms of the composite endpoint of death and heart failure rehospitalization. Now we are going to talk about ultrasound point of care. And we are going to focus on these three techniques: lung ultrasound, inferior vena cava ultrasound, and also renal venous Doppler ultrasound. And there are two protocols of lung ultrasound examination: scanning of 8 chest zones or of 28 chest zones. The simplified 8-zone protocol is increasingly used, not only in clinic, also for research. And what we look for with lung ultrasound is the presence of B lines, which are indicative of the degree of pulmonary interstitial congestion. The lines are vertical lines that arise from the pleural line and extend to the far file of the ultrasound screen. And in the 8-zone protocol, more than 2 zones on each lung with more than 3 B lines are suggestive of severe congestion, as well as in the 28th zone protocol, where more than 30 B lines in the entire lung are also suggestive of severe congestion. With lung ultrasound, we can also improve diagnosis of acute heart failure, as we can see with the results of this study that evaluated patients with dyspnea in the emergency room. After clinical diagnosis, the presence of more than 3 lines in at least 2 zones per hemithorax had greater sensitivity and specificity than NT-proBNP plus chest X-ray. But lung ultrasound also is a good predictor of prognosis. In this study, 187 outpatients with decompensated heart failure were evaluated with lung ultrasound. And the first ultrasound was done at baseline when the patients were apparently congestive, and second one once the acute heart failure, once the congestion was apparently resolved. If we focus in the baseline ultrasound, we can observe that those with less B lines had a much better prognosis in terms of the endpoint of the study, which was the composite of death and hospitalization at 30 days. In this study that also explores the prognosis utility of lung ultrasound in heart failure, in hospital acute heart failure patients were evaluated. In those patients, also 2 ultrasounds were done. First one at admission and the second one at discharge. We can observe that a significant reduction of B lines between the 2 scans realized had much better prognosis in terms of death and heart failure rehospitalization. And we can also use lung ultrasound for guiding therapy, as we previously said with CA125. In this study, 126 patients that had recent hospitalization because of acute heart failure, they were analyzed. Patients were randomized to 2 arms. In the first one, the diuretic therapy was guided by lung ultrasound instead of the second one, where the patient received conventional follow-up. As you can see in the guiding therapy, if patients had more than 3 B lines, an increase of diuretic therapy was recommended to the investigators. And as we can see in the graphic from the right, patients in the lung ultrasound guided therapy had less urgent visits because acute heart failure and less hospitalization and death. Now we are going to talk about inferior vena cava ultrasound. The concept is that any change in right atrial pressure is transmitted backward and modifies inferior vena cava size. Inferior vena cava higher than 21 millimeters that collapse less than 50% suggests high right atrial pressure. However, these techniques have some limitation, as happened, for example, with patients with severe pulmonary hypertension, patients with liver diseases, ascites or under mechanical ventilation. In fact, there has been described inaccuracy of right atrial pressure estimations when we use inferior vena cava ultrasound, as we can see with this study. Despite these limitations, inferior vena cava ultrasound has also provided with some advantages in heart failure patients. As we can see in this study, where 342 patients with heart failure were recruited, the use of this technique can improve heart failure diagnosis. Look, in those patients, inferior vena cava, lung, and jugular vein ultrasound was explored, and 47% patients where no clinical signs of congestion was found. They had at least one ultrasound sign of congestion. In 5%, the 3 ultrasound techniques were positive for congestion, and they had the greater NT-proBNP level. But it is remarkable that among patients without clinical signs of congestion, 30% had inferior vena cava diameter higher than 20 millimeters, and also they were related to higher levels of NT-proBNP. Inferior vena cava ultrasound also can provide us with prognosis information. In this pilot study of 70 inpatients with acute heart failure, 2 inferior vena cava ultrasound was done. The first one at discharge, and the second one in the follow-up at ambulatory clinic. As we can see in the table, patients that needed rehospitalization had higher inferior vena cava diameters and less collapsibility index at discharge and also in follow-up than patients free of rehospitalizations or death. However, in contrast with CA125, as we talked previously, and in contrast also of lung ultrasound, the use of inferior vena cava ultrasound in guiding therapy is currently nowadays under evaluation. As we can see, at least 3 studies are in progress to address this topic. And what about to renal venous and Doppler ultrasound? With this technique, we can identify 3 venous flow patterns according to renal congestion. The continuous pattern, the continuous flow pattern, a venous flow pattern, which is normal, and the other are biphasic and monophasic. This last one, the monophasic pattern, is the one that reflects the higher venous renal congestion. Renal ultrasound can also provide us some prognosis information in acute heart failure patients. In this study, heart failure patients, most of them recruited during hospitalization for acute heart failure. The 3 described patterns of renal venous flow were analyzed. As we can see in the graphic from the right, the monophasic flow had the worst prognosis, with biphasic in the intermediate level, and having the continuous flow, the better prognosis in the follow-up. But what I really think is important with renal venous ultrasound is that it has been integrated in a protocol with other ultrasound techniques. This allows us to create a score, which is the venous excess ultrasound grading system, also called as the VEXUS score. This protocol not only uses renal venous ultrasound, but also inferior vena cava, hepatic vein, and portal vein ultrasound. As we can see in the graphic from the right, if inferior vena cava ultrasound is suggestive of congestion because of more than 21 milliliters or low collapsibility, then the other ultrasound must be done, creating a score with the patterns observed. The real advantage of using this protocol in acute heart failure is shown in a study like this one. In acute heart failure hospitalized patients, the use of this protocol can predict a worsening renal function, as well as it is related with worse diuretic response. In the graphic from the right, we can see that patients with VEXUS 3 had more probability of deteriorate renal function and have the lowest urine sodium concentration after 2 hours of the first diuretic administration. And this is the last point. Finally, this table can look like an abstract that we can use as a kind of checklist before discharge in acute heart failure patients. As we can see, we again reinforce the idea of using a multi-parametric approach, not only with clinical signs, but also biomarkers. Obviously, CA125 lower than 35 units per milliliter should be added to this checklist, and also ultrasound protocols, and again, probably VEXUS protocol, I think that should be added. So that was the last point I wanted to share with you, and thank you very much for your attention.
Thank you. We would like to thank Jesús Casado for his great presentation containing some vital information about the current methods of diagnostic of congestion in heart failure patients. And now I think that we can move on to a brief question and answer questions. Just a moment, I will check. Yes, it's one of question from Alberto. Is there any role for right atrial area in the assessment of congestion? Furthermore, should the evaluation of lung lines be performed only at rest, or is there any role of the evaluation under exercise?
Well, usually they are done at rest, with the patient at rest, not with exercise. The usual performance of this technique is with the patient at rest.
Thank you very much. We have just a moment, yes. What is the role of JVD ratio?
Sorry?
What is the role of JVD ratio?
I don't really have much information about that, so I'm afraid I can't answer. I don't know if later any of you have more information of that, but I'm afraid I don't have it.
Thank you. Thank you very much. And one more question from Alessandro. Does the VEXUS score give us also a prognostic value for acute heart failure?
Yes, I already told about that. I mean, VEXUS 3 are a key to an open window to look for a worse prognosis in both readmission for heart failure and also of death in acute heart failure patient. It is well studied.
Wonderful. Thank you, Jesús. That's all. Thank you very much. And Antonio, I can.
Okay. Thank you very much, Jesús. And I feel deeply privileged to introduce Professor Mullens from Belgium. He's a full professor of cardiology, and is the president-elect of the Heart Failure Association of the European Society of Cardiology. And he also is the author of many seminal papers in the field of diuretics and congestion heart failure. And he will talk about tackling with refractory congestion and diuretic resistance. Professor Mullens.
Yeah, hello everybody. Good evening for most of you, I assume. Thank you, Antonio, for the introduction and also for the invitation to talk about congestion and diuretic resistance. These are my disclosures, so I'll try to explain to you what I think you should do in case of diuretic resistance or worsening renal function. And most importantly, this is not a problem, but this is just normal physiological response to heart failure. And in contrast to what you mostly hear, I'm going to start with my conclusions, so then you can leave if you're not interested anymore. So the first conclusion is that renal function is not the same as GFR or serum creatinine. Renal function is a lot more than that. Secondly, CKD, so chronic kidney disease, is very prevalent and it's related to adverse outcomes. Third conclusion, certain agents, so drugs, delay the progression of CKD, and of course, they need to be used as much as possible. Fourth, diuretic resistance or worsening renal function is not a problem, but it's just a normal physiological response. And my fifth conclusion is that you should never ever stop decongestion if you see worsening renal function occurring. So first problem, first of all, renal function is a lot more than GFR. GFR is just what's happening at the level of the glomerulus, but what is happening at the tubular level is even more important. So GFR tells you something about clearance, while tubular function tells you something about homeostasis. And you need to try to address both of them if you would like to assess renal function. Bear in mind that GFR-based definitions of renal insufficiency talk about CKD if you have a GFR below 60 mL per minute. And this is very prevalent. 50% of the heart failure patients have CKD, and CKD is a stronger predictor of adverse outcomes than ejection fraction. You normally lose around 1 mL of GFR per year once you reach the age of 50. But if you have heart failure, this goes up to 2 mL per year, and if you have uncontrolled diabetes, this goes up to 5 mL per year. So it's not a surprise to see that patients with heart failure or CKD will end up in dialysis if you don't treat their diseases properly. There are 2 drugs now for heart failure that we know that can lower down the decline in GFR, and that is Entresto, or sacubitril valsartan, and SGLT2 inhibition. So these are 2 very important agents to be used in almost every heart failure patient to lower down the decline in GFR. For diabetes, we have more agents. We have finerenone, SGLT2, and RAS inhibition. All of these agents have proven benefits on the decline of CKD, and also GLP-1 receptor agonists. Now, GFR, you can assess that very easily by taking a blood sample, but what is even as equally important is to do a urine analysis. Just take a small sample of the urine and measure the urine albumin creatinine range. If this is increased, this is also linked to worse outcomes. And you can have a normal GFR with an increased urine albumin ratio or vice versa. So a normal urine albumin, but a lower GFR. So both of them are equally important. So do the assessment by blood sample and by a urine sample to actually identify the patients that are at highest risk to develop worse outcomes. Now, going back at renal function urine analysis. If you would drink the water on the left, or you would drink water with sodium into it, what will make you pee faster? Most of you probably think if you drink the sodium, but that's incorrect. It's very easy for our bodies to lose water. It's very difficult for our bodies to lose sodium. The reason for that is if you drink water, you change your osmolarity. And if you change your osmolarity, your brain starts to swell. Our body doesn't like it when your brain starts to swell, so then you have to go to the toilet. However, if you drink water with sodium, that goes via the RAS system, and it's very difficult to lose sodium. Only patients with advanced heart failure have problems by losing water. Why is that? Well, that is because they have a higher release of AVP or ADH, that's the same hormone, in face of a higher oncotic pressure. So only patients with advanced heart failure will retain water. That's the reason why we put forward with it HFA this guideline document on sodium and fluid intake. We do not anymore suggest to restrict water and sodium intake if you have chronic stable heart failure. even if you have acute heart failure, it's okay to drink water. If you have acute heart failure, you just have to make sure that what you get out is more than what you get in. But a normal intake, which is around 2.5 liters of water and 4 grams of sodium, is allowed in heart failure. Now, why do heart failure patients have a tendency to retain more sodium? Well, this is just linked to RAS activity. Bear in mind that you cannot lose sodium in your gut. So everything that you eat will be absorbed by the gut. And humans have a very high RAS activity. That is because we're standing upright and we need a blood pressure of 120 millimeters of mercury. This is the pressure surrounding us is 760 millimeters of mercury, so you need a higher pressure, otherwise you will faint. So our bodies have a very high RAS activity. This is in contrast with fish. Fish living in the sea almost have no RAS activity because they have a lot of sodium around them, of course. So if you look at the kidney and sodium regulation, a normal kidney filters a tremendous amount of salt. A normal kidney filters around 1 kilogram of sodium every day. If you have a very bad kidney and a poor GFR of 10 mL per minute, you still filter 150 grams sodium per day. This means that if you eat 4 to 5 grams of sodium, that even having a low GFR is not a problem. You can still filter enough sodium. The problem is not the filter, the problem is the reabsorption of the sodium. So you filter at the level of the glomerulus, and then you have a very long tubule, and there is the urine. And what happens actually is once you filter the sodium in the water, that it will be reabsorbed along the nephron. Most sodium and water reabsorption occurs in the proximal parts of the kidney. This is exacerbated, increased if you have heart failure. So if you have heart failure, there's an increased sodium reabsorption, especially in the proximal parts of the kidney. And bear that in mind when we're going to talk about diuretic therapy. We actually advocate, or we strongly suggest, that you have to rule out signs of congestion, just like Jesus told you, before you discharge a patient home when you admit them with heart failure. The kidney has a pivotal role in that. If you have an elevated central venous pressure, you have a higher likelihood that you will develop worsening renal function. This is not a surprise, of course, because the kidneys get a tremendous amount of blood. But a higher central venous pressure actually interferes with a normal kidney function. And you should do your best to lower down the central venous pressure as well. So what drugs do we use? Well, we use diuretics. We give still to loop diuretics a class 1 recommendation to be used to treat signs and symptoms of congestion. And for thiazides, we give a class 2A recommendation. If you look, however, at loop diuretics, almost all of our patients are diuretic resistant. What does that mean? It means that if you would infuse yourself with 40 milligrams of furosemide, you should be peeing out around 3 liters of water and sodium. This does not occur if you are already on a loop diuretic at home. And this is what we call diuretic resistance. So patients who are on diuretic therapy at home do not respond in a normal way if you compare them to patients who did not take a loop diuretic at home. This is what most people know. What most people don't know is that if you only use loop diuretics on a daily basis, that the quality of the urine is dramatically changing. The quality meaning the amount of sodium in the urine is dropping if you use only furosemide during consecutive days. This means that every day you can still lose some water, but you don't lose sodium anymore. And this is a problem because I strongly believe that sodium is a culprit and not so much water. In order to overcome the poor utilization of diuretic therapy in heart failure, we wrote this document. And this is probably the most cited document ever that I've ever written, and also the most downloaded document. More than 500,000 people already downloaded this document. Why? Because it has a lot of practical flowcharts. Let me guide you through the most important rules with regards to loop diuretic therapy. First of all, door to diuretic time. If you see a patient with congestion, just give the IV loop diuretic therapy as soon as possible. There is absolutely no reason to wait for anything. For what? Just give it as soon as you see the patient. Next rule is that you have to evaluate the effect of the diuretic therapy. This is very important. If you give an antihypertensive agent, you measure blood pressure. If you see a patient with a STEMI, with a myocardial infarct, we measure the flow in the coronary arteries. If you give a diuretic, you have to measure what's coming out. How to do that? Well, this is depicted in this flow chart. If you are faced with a loop diuretic naive patient, so a patient who was not on a loop diuretic, you just give him 40 milligrams of furosemide IV bolus. If the patient was already on a loop diuretic, you give them 80 milligrams of furosemide. So you double the dose that the patient was taking at home. If he was taking 80 milligrams, you give him 160 milligrams IV bolus. And then, very importantly, you have to evaluate the effect of the diuretic. We give you two options to do. Either you measure urinary volume, which should be at least 100 cc's per hour. But that is difficult to do because it's difficult to measure urinary volume. It's a lot more easier to measure the urinary sodium concentration. You take a sample of the urine, you send it to the lab, you look at the urinary sodium concentration, and that should be at least 70 millimoles per liter. If you don't reach the urinary sodium of 70, or you don't reach a urinary volume of 100, you have to double the amount of loop diuretics straight on. If you reach the threshold of 70 millimoles of sodium or 100 milliliters of urine, you just give the same amount of loop diuretic therapy twice a day. So this is a very practical flow chart that will help you to guide diuretic therapy better. Now we talk about urinary sodium analysis. This has led to a tremendous amount of studies looking at desalination guided therapies. This means looking at the urinary sodium and then changing the therapy according to what you have measured. This is the ENACT study. This was a multi-center prospective international trial. PUSH-AF was a single-center trial done in Groningen in the Netherlands. Both trials showed an impressive increase in natriuresis, in diuresis, and a reduction in length of stay if you just measure the urinary sodium for the first 2 days, which might help you to guide diuretic therapy better. I know this might seem cumbersome, but it's a lot easier to measure sodium than it is to measure urinary volume, because my patients, they pee everywhere, but they don't pee in the bucket that I give them to use to collect urine. Most of my patients don't want a Foley catheter, so it's very difficult to measure urinary volume, while it's not difficult to measure urinary sodium. If you don't want to send it to the lab, you can now use this urinary sodium point of care sensor. This is a sensor made in Japan. It costs 250 euros, and you drop a bit of urine on the stick and you see the result immediately. When you use this point of care sensor in this trial that we've done, you can also increase the amount of urinary sodium excretion. Now, another problem that many of you see arising when you treat patients with acute heart failure is worsening renal function. You see an increase in creatinine, you see a decrease in creatinine, and you don't know what to do. So how to approach patients with worsening renal function? The first thing is, this is not a tremendous problem for the kidney. This is not true AKI. When we measured NGAL levels, this is a measurement of renal damage, these are not elevated. Patients who have worsening renal function during acute heart failure do not have intrinsic renal damage. So this is not a damage to the kidney. So how do you approach this? When I'm faced with a patient with worsening renal function while I'm giving decongestive therapy, you have to assess the diuretic response. If there was a good diuretic response, meaning urinary volume of more than 100 cc's per hour, urinary sodium of more than 70 millimoles per liter, I don't care. This is called pseudo-worsening renal function. You don't care, you don't look at it, you just continue your decongestive efforts. If, however, your diuretic response was poor, you have to rule out hyperperfusion. Hyperperfusion is shock. Shock means inotropic support. Shock means an LVAD or a mechanical circulatory support. Shock is rare. This happens in 1% of the patients. Most of the times there is no shock. You just need to intensify your loop diuretic therapy, and you should consider IV vasodilators. Why IV vasodilators? Because blood pressure does not equal flow. You can have a high blood pressure but no flow. My kidneys don't care about blood pressure, they care about flow. And you can improve flow by giving a vasodilator. Because if you give a vasodilator, you open up the vessels and you increase forward flow. My favorite vasodilator is nitroprusside. You can give it easily via continuous infusion, and you just let the nurses measure blood pressure. If the blood pressure is around 60 to 70 millimeters of mercury, mean arterial blood pressure, you increase the dose of nitroprusside, you increase flow to the kidneys, you decrease signs of congestion, and you increase the diuretic response. What are the other diuretic agents if you want to add something to a loop diuretic therapy? The first one is spironolactone. You can give high versus low spironolactone. This was tested in the Athena trial. Usual care was 25 milligrams of spironolactone. Spironolactone was 100 milligrams of spironolactone. It did not make any difference. So increasing the dose of spironolactone will not help you to decongest patients easier. This is not to say that Spiro is not important. Spiro should be given to every patient with heart failure lifelong as a disease-modifying therapy. But increasing the dose of spironolactone is not going to help you to decrease congestion. What about thiazides? Jesús was part of this trial. This was the chlorotic trial. It was a fantastic trial run in Spain with very limited amount of money, comparing in patients with volume overload on loop diuretics, the addition of hydrochlorothiazide versus placebo. They showed that if you add hydrochlorothiazide, that you have a little bit more rate reduction by adding the drug to loop diuretic therapy, which is a significant, important endpoint. However, the trial investigators did a sub-analysis, and what they showed was that if you have a low GFR, that the thiazides did not lead to an increased weight loss. And this is a problem, because most of my patients who have a low GFR do not respond well to diuretic therapy, and they need the addition of a second-line agent. And they show in this trial that if you add hydrochlorothiazide to loop diuretic therapy in patients with low GFR, that you don't really see a very much impressive increase in rate reduction. The other problem with chlorotic or with the thiazide is the very high likelihood of hypokalemia. This was a trial setting, and even in the trial setting, they saw 50% of the patients developing potassium levels below 3, and this is very dangerous. So if you use a thiazide, be aware of hypokalemia and already treat your patients with potassium supplements to avoid this detrimental complication, because if you have low potassium levels, you have a very high likelihood to develop arrhythmias, which can be life-threatening. I talked about diuretic therapy, and now I go back to the nephron. The nephron is very long. Loop diuretics work at the level of the loop of Henle, thiazides work distal, and MRAs work also distal. I told you before that most of the sodium is reabsorbed in the proximal parts of the kidney, so it does make sense to add an agent that would block proximal sodium reabsorption. Which agents do we have that block proximal sodium reabsorption? Well, the first one is an SGLT2 inhibitor. It blocks glucose uptake, and it also increases sodium excretion a very little bit. Not much, but a very little bit. So if you add an SGLT2 inhibitor acutely, you will have mostly an osmotic diuresis. But we will never use these agents as acute heart failure therapies, because in the future, everybody with heart failure will be on an SGLT2 inhibitor. So these are not agents to be used acutely in the future anymore to treat signs of congestion. They're used to prevent congestion, not to treat congestion. Is it safe to temporarily stop an SGLT2 inhibitor? Absolutely not. This was data from the EMPEROR trials in HFpEF and in HFrEF, where they stopped pre-specified for 1 month empagliflozin in heart failure patients. And what they saw was an increase in heart failure hospitalizations and a decrease in quality of life. So it's not safe to stop an SGLT2 inhibitor for 1 month because you think you should be doing this. What is the other agent that blocks proximal sodium reabsorption? Well, it's the oldest diuretic agent that we have. It's acetazolamide. Acetazolamide blocks carbon anhydrase at the proximal tubular level, and it therefore interferes with the sodium proton exchanger. And it can lead to a doubling of the amount of sodium excretion if you add acetazolamide on top of loop diuretic therapy. This pivotal study we've done almost a decade ago led to the design of the ADVOR trial. ADVOR was a prospective, randomized, multi-center, double-blind trial comparing in acute heart failure patients with volume overload, standardized IV loop direct therapy plus placebo versus standardized IV loop direct therapy plus once daily 500 milligrams of acetazolamide intravenously. Was a multi-center trial done in Belgium. And what we did is, as a primary endpoint, is your patient dry? Dry assessed by the presence of edema, pleural effusion, and ascites. So patients dry were patients without extravascular volume overload. So no edema, no pleural effusion, and no ascites. That was our primary endpoint. Is your patient dry after 3 days of consecutive diuretic therapy? We saw an impressive improvement in the number of patients dry after 3 days. This was a primary endpoint with the combination of IV loop direct therapy plus once daily acetazolamide. We saw a 46% higher likelihood by adding this agent. I know you think, I don't use acetazolamide, I do something differently. Well, guess twice, because if we looked at the numbers at discharge, there still was a spectacular increase in the patients that were upfront treated with 3 days of acetazolamide. Number needed a treat of 6. The drug cost €8. €8. For 3 days, €24. So for €24, you can save patients, you can improve their decongestion rates in a very safely manner. Why is the drug so effective? The drug is so effective because it prevents loop diuretic resistance from happening. If you block proximal sodium reabsorption, you boost loop diuretic efficacy. So it's very, very physiological, very clear. If you block proximal sodium reabsorption, the loop direct therapy will become more effective. So you need to combine a proximal working agent with a more distal working agent like acetazolamide. It's a very effective therapy. So we said it's time for door to combo diuretic time. Now I'm just going to talk 1 minute about when can you stop loop diuretic therapy in ambulatory heart failure patients. There is no clear guidance on this. I think there are several conditions for which you can think that you can successfully down titrate loop diuretic therapy in ambulatory heart failure. First of all, they need to be on maximally tolerated doses of GDMT. What is GDMT? ACE or ARNI, MRAs, SGLT2, beta blockers. Patients need to be compliant. You should not see any signs of congestion anymore clinically or by any technical exam that Jesús just explained to you. They should have a normal diastolic function and a normal NT-proBNP. And then you probably can stop the loop diuretic therapy. So this is my final slide. This is the way I look at acute heart failure. So for the acute phase, I use an individualized natriuresis-based dosing of loop diuretics. I always add acetazolamide if my patient was already on oral loop diuretic therapy at home. I switch them to an oral regimen of loop diuretic therapy once the patient is dry, and I try to stop the loop diuretic once the patient is on GDMT. I never ever give acetazolamide chronically. I switch it to an SGLT2 chronically because these are disease-modifying agents. We try to up-titrate the GDMT, and we actively screen for comorbidities that you can also treat, like iron deficiency, hyperkalemia, diabetes, hypertension. These are things that you have to treat in order to avoid further decompensations in the future. I thank you for your attention, and I'm more than willing to address any remaining questions you might still have.
Thank you very much, Wilfried. It was a very terrific talk, and I'm sure there will be lots of questions. One question is that I would like to ask you is about the promotion of excretion of free water, that is aquaresis. You were mainly focused on natriuresis. What do you think about aquaresis in the decongested patient?
Yeah, so for aquaresis, there is one agent which is called the vaptans that can be used to actually induce aquaparesis, so more water excretion. That has been tested in the Everest program, and it didn't show any benefit. So I think we need to get out sodium and water, but more sodium than water. If we talk about ultrafiltration, which is a mechanical way to remove water and sodium, I still believe in the technique. I even think it's a very good technique because in that way you remove isotonic solutions, so more sodium even than with diuretic therapy. But we only reserve that technology for patients who are really diuretic refractory. So on very high dosage of diuretic therapy, in those patients we consider using ultrafiltration.
Thank you. There is a question from Andres Reseño. It is safe to combine SGLT2 inhibitors if we need to use acetaminophen. Is there any antagonist mechanism which can lead us to a treatment failure? Is there any evidence about it? Thank you for both of you for your fantastic topic.
Thank you for the compliment, Andreas. There is absolutely zero risk to combine them, and they work completely different. So SGLT2 block glucose uptake, while acetazolamide blocks carbon anhydrase, so they have a completely different mode of action, so you can use them in combination. Again, I think SGLT2 inhibitors are pivotal therapy lifelong for heart failure, so that's a completely different therapy than acetazolamide, which should only be used temporarily. There is no risk to combine them, and they work additionally on top of each other.
Thank you. There is another question about the comorbidities, in particular, the effect of for both of you, maybe, I don't know, about the effect of diabetes, in particular on vascular permeability. A comment about this.
Well, I think diabetes patients, they are always more difficult to treat because they also have more comorbidities, of course. And I think for diabetic patients, it's even more important that you start the chronic life-saving therapies. We have now GLP-1 agonists. I know there is a lack of, how do you say it? There's a supply problem, I think, in most countries, also in Europe, in Belgium. But GLP-1s are fantastic therapies for diabetes, to lose weight, to improve renal function. I mean, these are the agents that should be used preferably in diabetic patients. It's a very important thing also for internal medicine doctors that there are a lot of bad diuretic therapies. There are a lot of diuretic therapies which cause harm. So it's our pivotal task to stop these harmful diabetic agents and change patients to SGLT2 and GLP-1. But I don't know what Jesus thinks about this.
What is your experience with the metolazone, like adding metolazone to?
Yeah. I think metolazone is comparable with hydrochlorothiazide, and I'm not against these agents. So maybe Jesus should comment on this as well, because he was part of the chlorotic trial, of course. But I think if you use thiazide or acetazolamide, I don't care what you use, as long as your patient is dry when you discharge him. That's the most important rule, and you put him on GDMT, so on the life-saving therapies. I personally prefer acetazolamide because I think physiologically it works better. But in patients who are chronic on very high doses of loop diuretics, I think thiazides also have a role. But Jesus, what do you think of it?
I think I totally agree with you. And there is no a real study that addressed the topic of using metolazone as we did with hydrochlorothiazide. So there is a question difficult to resolve which one is better. Perhaps from pharmacokinetics point of view, metolazone is more potent, but there is no real study to address this topic. So until more evidence, I think if we have to use a thiazide, better hydrochlorothiazide.
Then there was another question in your daily practice. What are the biomarkers that you are using in your hospital of tissue congestion, intravascular congestion? What are the biomarkers that you use in your daily practice?
Yes, just the two of them that I talk about. I mean, NT-proBNP and CA125, they are relative. Every hospital have these biomarkers. They are quite cheap, and there is no problem to use them and very widely used. So in clinical practice, they are the two biomarkers. There are a lot of them. There are a lot of biomarkers for addressing the topic of congestion, but perhaps in clinical practice, these two are the more used.
Vera, do you have a comment?
I think it's very interesting presentations, but I think about one sign such as band apnea, and I would like to ask Jesús, what is your opinion about this fast and simple clinical marker about congestion?
Yes, as I told when I shared the presentation with you, as I talked previously, I mean, just a sign or just a symptom has a low sensitivity and specificity even for band apnea. I think, of course, it's easy to address band apnea, to ask for and to represent, but just talking about band apnea as a single marker is not good enough. We have to try to avoid use just a sign or a couple of signs or a couple of just biomarkers. We don't have to address congestion this way. We have to make a whole picture of the situation.
Yes, thank you.
Okay, so I think there are no more questions. I think it's also 7 p.m. so we can close this webinar. I really thank you everybody. I thank Wilfried and Jesús for participating and all the people that are online. And it was really very good. Thank you very much. Thank you to everybody.
Thank you.
Thank you all.
And I also would like to thank European Federation of Internal Medicine and my co-moderator, Professor Antonio Cittadini, for organizing this wonderful event. We thank our speakers for their profound and thought-provoking presentations and the participants of today's webinar for their involvement. Thank you very much.
Thank you. Bye-bye.
Thank you very much. Bye.
Bye-bye.